and I will be moderating the conference today. I am a longtime volunteer with the Lupus Foundation of Northern California, and I'm excited for today's presentations. As Tom mentioned, in the first hour, we're excited to hear from Dr. Reejhsinghani as she discusses managing cardiovascular risk in lupus patients. After her presentation, we will have 15 minutes of live Q&A. We'll be moderating the questions, so you can type your questions whenever you want during the presentation. Welcome, Dr. Reejhsinghani. Please go ahead and get started.
Okay, well, thank you so much, Sitara, and I wanted to thank Tom for that really kind introduction and to the Lupus Foundation for inviting me today. It's a pleasure to be here with all of you. I'm going to get started and share my slides. Okay. All right, so again, this is a topic I care about very deeply. This is what I see in my clinical practice. We see a lot of patients with lupus, but with a whole host of autoimmune disease. And we know now that there is a lot of work that we can do upstream to manage cardiovascular risk, to identify it, and to treat it just a little bit differently than we would in patients who don't have autoimmune disease. And so I'll be, talking about this a lot, but one easy example that comes to mind is patients with diabetes. In patients with diabetes, they may not have cardiac disease, but we know based on research that they can have a pretty high risk or an increased risk of cardiovascular conditions. So we treat them just a little bit differently in terms of managing that risk, trying to find out if they have symptoms, making sure their cholesterol and blood pressure is well controlled, their blood sugars are well controlled. So we do a similar thing for patients with autoimmune disease, but I will say we don't have enough research in this field to know exactly what we should be doing. So we kind of try to make our best estimate, and we try to use all the available research, which over time the rheumatologic societies have definitely been a lot more focused on this, as have the cardiovascular society. So we are in a much better position to manage this now than we were even 5 or 10 years ago. So just to start with, this is a painting that hangs in the National Gallery in DC, painted in the 1800s, and it was painted by a gentleman named Jean-Baptiste Camille Corot. And if you see closely, and this reappeared in a medical journal in 1990, and maybe they took some liberties, but what they described was this lady who was painted with boutonniere deformities of her fingers, swelling of the interphalangeal joints, and maybe some tophi, which are calcific deposits in her joints. And it was felt at the time that he was painting himself. The painter had gout, and so he was painting his reflection in this lady. And so that is, the time from which rheumatologic diseases have been prevalent in society. We see it from, ages ago. But in terms of treatment, we're at a different era right now than we have been for several decades.
Dr. Raj, I apologize. We're not able to see your slides right now.
Oh, I'm sorry. Okay, let me see.
Okay. It was just that last part with the painting. Would love to see
Okay,
that.
can you see the painting now?
Not yet.
No? Yeah, okay. Okay, let me know if there's an issue again. So now I'm just going to cover cardiac abnormalities in several rheumatologic diseases, focusing on lupus, but it's a kind of a good idea to know, because a lot of times, lupus is not an isolated condition. There are patients who have overlap, who have mixed connective tissue disease, undifferentiated connective tissue disease, where lupus can be a part of it. So it's good to know what cardiac abnormalities are prevalent in different types of conditions. So first, when we talk about mechanisms, the mechanisms that cause cardiac disease or cardiac damage in autoimmune disease have been found to be both a function of traditional risk factors, which I'll talk about in a moment, as well as disease-specific risk factors, which vary between different types of autoimmune disease. So our traditional risk factors are things like high cholesterol, smoking, high blood pressure, lack of exercise, diabetes or blood sugar resistance, obesity. Those are the traditional risk factors for any patient who has, coming in with cardiac disease. And then for the autoimmune diseases, they've found different types of conditions and molecules that will drive inflammation, and that inflammation can lead to cardiac risk, specifically things like blockages in the heart arteries, which can lead to heart attacks, strokes, if it's in the brain circulation, as well as things like inflammation of the heart muscle, valvular abnormalities, those kind of things. So this slide I have up here on the left, if you look at lupus specifically, you have the anti-dsDNA antibodies, the interferons, and other molecules like that, which will activate white blood cells and cause these different molecules to actually deposit within the tissues, and they can trigger inflammation and trigger an inflammatory response, which either heals with scarring or cholesterol deposition or other things like that. So we look for those specifically, and rheumatoid arthritis has its own set of molecules, vasculitis, and other conditions. There's a whole host of interactions that go on here that we do know quite a bit about now that can trigger these, and that's where the second piece of it. So managing cardiovascular risk in autoimmune disease is very much a twofold process. One process is really managing traditional risk factors, so making sure blood sugars are well controlled, cholesterol, blood pressure, enough exercise, good diet, those kind of things. And then the other piece of it is managing inflammation, which is where we partner with rheumatology. So they really drive this part. But to protect the heart, you need to make sure the autoimmune disease is well controlled. And that is not always that easy. Some patients respond very well to immunomodulation. Some patients will require a variety of different medications to manage their condition, but that's the part that's very, very key to managing the cardiac risk as well. Okay. And I'm going to go over this quickly, but essentially this just tells us that there are different mechanisms of cardiac abnormalities in autoimmune disease. So this has a lot of words in it, but just to simply state it, with something like systemic sclerosis or scleroderma, you can get pulmonary hypertension. With lupus, you can have pulmonary hypertension, but the mechanisms are very different. In lupus, it's much more about having blood clots in the arterial circulation, the lung arteries, whereas with scleroderma, it's much more about having what we call a vasculopathy, and it heals with kind of obliteration of that artery. So it's just different mechanisms, and the more we know about this, the more we can treat it from a pathologic standpoint. Okay. Now I'll move on to the actual autoimmune conditions themselves and what kind of cardiac complications you get. I will say that this is based on research, but there's not a lot of research underscoring this. So what ends up happening is we will treat patients with autoimmune disease as patients who have increased inflammation, increased cardiovascular risk. And when they have specific cardiac conditions that are uncovered, we do manage them a little bit differently in terms of managing the autoimmune condition itself. So, my focus, and I will start with lupus. Lupus has a variety of different autoimmune conditions that have been, cardiac conditions that have been described. The most common is pericardial disease. So pericarditis, inflammation of the lining of the heart. So the heart is covered by a pericardial layer that can get inflamed. And this is no different in a way from having the rash, the joint involvement, the kidney involvement. This is the cardiac involvement. So it's just a different manifestation of the condition. So you can certainly have inflammation in the heart lining, which can cause chest pain. It can cause fluid to develop and deposit there. And in rare cases, you can also have inflammation of the heart muscle, which is much more concerning. And that is something that can be quite dangerous if it's not treated appropriately and if it's extensive. So that's where you have the same, autoimmune condition that causes the heart muscle to be inflamed, have a little bit of, fluid in it. And then essentially that can cause arrhythmias, that can cause damage to the heart pumping function overall. The other thing that's been well described in lupus is valvular disease, which is essentially, you can have thickening of the valves. This has been studied for the last maybe 50, 60 years, where they've done it both in patients and as well as autopsy studies. And essentially, you can have thickening of the valves. You can have conditions where there are little depositions of what we call vegetations on the valves, which can affect how they open and close. So that's the main thing. And then we talked about pulmonary hypertension a little bit. the same little blood clots that can form in other parts of the body can form in the pulmonary circulation. So that's the lung circulation. And that can lead to increases in the pressures in the lungs, which eventually has a backwards effect on the heart, and that can affect the right side of the heart. Okay, so we do have some research that came out for lupus patients with cardiovascular risk. There was a doctor called Mary Roman who did a lot of work in the early 2000s, and she did the study where they had 197 patients who had lupus as well as several patients who did not. And what they did is they tried to compare them to see if they had increased cardiovascular risk. And and what ended up happening is when they did ultrasounds, both of the heart and the carotids, they did see that there was more carotid plaque, so plaque deposition in the carotid arteries, as well as, kind of an increased overall cardiac risk in patients who had lupus. And they did match them to make sure that, they were equivalent in terms of smoking, and they had been matched for other conditions. So what they surmised from the study is that patients who did have cholesterol plaque, they'd had a longer duration of lupus, they'd had more severe lupus, and they were older. So they did find something that we can intervene on early, because we can, screen for this in lupus patients, and we can certainly treat them if their cholesterol is high. We talked a little bit about the valvular disease in lupus. So this is back a long time ago, 1924. Emmanuel Libman and Benjamin Sachs. So one of them was a pathologist. One of them actually was a physician who worked with the film industry to make sure their sets looked good and were medically appropriate. And so both of them came together, and they had described this condition in patients where they had seen patients who were really, basically those were cancer patients at that time, or who had chronic diseases. And these patients, sorry, I apologize, I have a cough. These patients were found to have these little, what we call vegetations on their valves. And I will pull that up. So this was named after these two gentlemen as Libman-Sachs endocarditis. And what it really is on the valves of patients with, cancer, other chronic diseases like tuberculosis, but also with autoimmune disease, particularly lupus and antiphospholipid antibody syndrome. Patients were found to have depositions of what we call fibrin. So fibrin is a protein that with little blood clots, and that actually affects the way the valve closes. And when the valve doesn't close well, it tends to leak. And when it tends to leak, it can cause, damage to the heart and damage to the function overall. So that is what was described at the time as Libman-Sachs endocarditis, and it's something we see in practice to this day. And here I'm just going to play a couple of videos. You see on the left, it's a case of a 29-year-old male who had a stroke, and who had SLE and had an acute stroke. And what we see here is, I'll explain this. This is the mitral valve. It's one of the left heart valves, and you see that this valve at the top portion, as it's thin, it's moving well. But if you see at the bottom where the valve is actually closing here, there are depositions on this. So these are vegetations. These vegetations are made of, like we said, proteins and blood clots and things like that. They're not infected. There's no bacteria there. They're sterile, but they do sit there and prevent this valve from closing. And what happens is, the other part of these is they can grow and they can break off. So what has happened in this patient, unfortunately, is that the vegetation got big enough that it broke off, and it went to the brain and it caused a stroke. So these are things that we need to, monitor in patients who have symptoms to make sure that we're not missing something like this. And then on the right over here, I have another case that was published. This is a 38-year-old female who also had a mini stroke, where they had a stroke-like presentation which improved. And this is the aortic valve in cross-section. And I'm not sure if it's playing very well, but you can see that there's, the valve leaflets is this kind of Mercedes-Benz sign. And then there is a kind of a shadow here where as the valve is closing. So that's another Libman Sachs vegetation that also migrated, broke off, and caused a mini stroke. And then here I have some images of how you can have heart muscle involvement. So we talked about the lining of the heart, we talked about the valves. This is the heart muscle itself. These are MRI pictures on the top. So this is the left ventricle. This is the main pumping chamber of the heart in cross section. And you can see how it's nice and thick up here. And then there's an area that's thinned out. And that area also lights up on a specific scan, which suggests that it's actively inflamed. And that's suggestive of myocarditis or inflammation of the heart muscle, which is rare in lupus, but it can cause a lot of problems when it happens. At the bottom, what we have is the same pumping chamber in a different patient, where you see this area is darker. And what happens is that, there's this patient has had a blockage in the heart artery, so a heart attack basically, and that has caused damage to this area of the heart muscle. Okay. And then, the other condition that we think about a lot associated with lupus is antiphospholipid antibody syndrome, common in younger women, but can happen in any patient. So these are, it's associated with lupus, it's associated with its own cardiac findings, but often with things like Libman Sachs endocarditis that we talked about, vegetations. And basically with antiphospholipid antibody syndrome, patients are more predisposed to blood clots and blood clotting. And here we see that they can have blood clots in various different places, including the heart artery. So this is a specimen of a patient who's had damage to the heart arteries. And on the top, we have a patient who had what we call rupture of one of the valves, which is also associated with this condition. So again, it's very rare, thankfully, but we need to have, as cardiologists and as rheumatologists, we need to have a high index of suspicion for patients with autoimmune disease who come in with cardiac problems to make sure we're treating them the right way. Okay, and now I'll very briefly touch upon some of the other conditions and what's associated with them. So rheumatoid arthritis actually is one of the more common autoimmune conditions and tends to have a lot of cardiac involvement. There's a lot more research about this as well. So with rheumatoid arthritis, actually, the EULAR and the ACR actually did have guidelines that said you can treat these patients as if they have diabetes. And by that, I mean that their cardiac risk is equivalent to someone who has diabetes, so higher than the general population. So for these patients, we do make sure that we check their cholesterol, that it's appropriately lowered, that we make sure their blood pressures are well controlled. If they have any cardiac symptoms, we'll test them for cardiac problems. But again, they can have, besides having heart attacks and strokes, they can have a higher incidence of pericarditis and pulmonary hypertension as well, because often they have lung disease, which can cause that. So a similar study to the one they did in lupus patients, they checked in on patients who had rheumatoid arthritis, and they were also found to have an increased risk of cholesterol plaque in the carotid arteries. So again, even if and they matched them for smoking history, for cholesterol levels, for all the other things. So they really did feel that it was a rheumatoid arthritis that was causing this. And then these are just some images of patients who have valvular conditions with rheumatoid arthritis. It may not be projecting very clearly, but the valves in these echocardiograms do show a little bit of thickening. They sometimes don't close as well. So often you have these findings. I will say sometimes they're very, very mild and they don't cause any problems, and we just monitor patients for symptoms. And then this is the pericarditis with rheumatoid arthritis. So this is a patient who had rheumatoid arthritis, came in with chest pain, was found to have inflammation of the heart lining, which is pericarditis, but that had also secreted some fluid. So that we call this a pericardial effusion. And this was a very big one. So it was compressing the heart, so it needed to be drained. Yeah. Spondyloarthritis, also a good amount of research on this, tends to increase the risk of heart attacks, of having cholesterol plaque in the heart arteries, can also cause valvular disease and disease in the heart muscle, but that tends to be less common. So again, with psoriatic arthritis and psoriasis, patients can have an increased risk of cardiovascular disease, also found to parallel the skin disease itself. And the best way, similarly, the good news is the way we treat this is to manage the cardiovascular risk overall, which is fairly similar in all patients. So, I'll talk about this in more detail at the end, but blood pressure, blood sugar, cholesterol, smoking history, we try to make sure we get on top of all of that. And then the guidelines have shown that it's important for patients to really follow up with their primary care cardiologists, or for instance, their primary care physicians or cardiologists, whoever they're managing, to make sure that their risk is overall lowered and that they're being evaluated in a separate way, in a way that actually manages cardiac risk and not just the autoimmune condition itself. Okay. And then they actually had a really nice paper in the Journal of the American College of Cardiology, where they had all the variables, the pathophysiologic variables, and they really showed that if you work on these risk factors on the left, you can actually manage and reduce the cardiac risk in these patients. Okay, and then the last couple of conditions I'll talk about is systemic sclerosis. This is a condition where, there's a lot of fibrous tissue deposition in the skin, in some of the internal organs. And the good news is it doesn't tend to have cardiac involvement very often. But when it does, it's something that we tend to see in our clinics because it can be quite severe. Sometimes there can be fibrosis or scar deposition in the heart, which can cause problems with the heart function, which can reduce the effective contraction of the heart and can also trigger arrhythmias. But again, very, very rare. The other thing that's common, much more common in systemic sclerosis, is pulmonary hypertension, which we talked about in the beginning. And with pulmonary hypertension, actually, they can have a good amount of damage that can happen very quickly to the lung circulation. And so this is something that the rheumatology guidelines have told us that we need to screen for. And we need to make sure that these patients are very appropriately checked every year with an echocardiogram to see if they're developing this, and if they're developing it, they need additional testing. And this is the last condition I'll talk about, which is Takayasu's arthritis. These patients come usually when they've had some damage to the aorta, or they've had issues with their circulatory response. And again, it's something that we see in younger women, and it can really be a problem in patients in the reproductive age group as well. They can have, scarring of the aorta, aortic aneurysms, and issues with the overall circulation, but they can also have aortic disease in the heart muscle and the valves. Again, not very common. The most common is inflammation of the aorta and the arteries. Okay, and with that, I'm going to switch gears and I'm going to talk a little bit about the risk management in rheumatologic diseases and what the guidelines show. So EULAR, which is the European League Against Rheumatism, they have had updates on this, and they have been releasing these guidelines for several years now. This is the most recent update they have, so they keep updating their guidelines every few years. This update was for patients with lupus specifically, where they really divided it into, lupus with kidney involvement and lupus without kidney involvement. And what they saw is what their research, so these recommendations are based on the available research as well as expert consensus. So they take a lot of people who know a lot about these conditions, and they have them agree on the research available and what the recommendation should be. So with lupus, they suggested that non-pharmacologic interventions, so, non-medication related interventions, including things like stopping smoking, healthy balanced diet, regular exercise, these were really important to improve long-term outcomes. And you'll see that the agreement for this was 100%. So everybody agreed with that. And similarly, reducing cardiovascular risk here at point number 13, that should be performed in all patients. So basically, all patients with lupus, the rheumatologists are very good at doing this as well. But if, they want additional help, certainly meeting with a primary care doctor or a cardiologist to make sure that their risk of cardiovascular disease has been appropriately addressed. And I will say it's not just the autoimmune condition. There can be family histories, there can be other things in patients' histories that it's good to combine and see if, that elevates their risk overall. And similarly, this is from the same EULAR guideline document where they said general measures that all patients with lupus should be having in addition to their medications is to exercise, no smoking, and normalize body weight and blood pressure and cholesterol and blood sugar control, as well as vaccination. This was the same society that released a specific cardiovascular risk management guidelines in 2022, which said that really and it was not just for lupus, they did it for a variety of conditions, including gout, systemic sclerosis, because a lot of the information overlaps and a lot of the ways to manage these conditions is very similar. So for lupus, the recommendation was clinicians should be aware that there is an increased risk of cardiovascular disease. And trying to reduce disease activity, just like we talked about, trying to make sure the lupus or any of these conditions are well controlled is going to improve the risk of cardiac disease in the long term. And then the other thing was that risk factor screening should be performed regularly. So, just because someone has seen a primary care doctor once and their cholesterol is good, their blood pressure is good, it doesn't end there. This really needs to be done, within 6 months of diagnosis, and also routinely, so maybe once a year or depending on the individual case, but it should be something that's monitored regularly. In most cases, if there aren't too many problems, a primary care physician can monitor this very effectively, or a rheumatologist. But if there are other things in the patient's history, a family history, or if they have symptoms, cardiac symptoms, then it is a good idea for them to see someone from cardiology. And then this was an older update, but I just wanted to put this here to, see how much they've emphasized cardiovascular disease risk assessment for all the autoimmune conditions, and how that is something it looks like all the data and all the experts generally tend to agree with. And most of it is centers around the tenets we talked about, like blood pressure and cholesterol. But for certain conditions, there may be some data to suggest that it is a reasonable idea to get a carotid ultrasound. And that's, based on the rheumatoid arthritis research I showed you. And certainly any patients who have symptoms should be screened more with the appropriate cardiac testing. So, a lot of the risk reduction we're talking about is in asymptomatic patients. But if someone has cardiac symptoms, then you take it up a level and then they should get the appropriate testing and appropriate screening. And then again, we've had some really good papers, not specifically necessarily about lupus, but about all the different cardiac conditions. And so in psoriasis, there was a paper in the American College of Cardiology journal that showed us how we can try to improve cardiac risk and how we can try to mitigate that in the long term. And it's not very different for lupus. Like I said, there's an overlap between all the autoimmune conditions. So they've broken this down very nicely, which is why I wanted to show this, because this is, truly applicable for lupus patients as well. So first you screen for all these factors that you can try to improve or change. And you also look for cardiac comorbidities. Things like, obesity, things like, a poor diet or a genetic risk of elevated cardiac disease, etc. And then in patients who have symptoms, you may get, diagnostic testing. In patients who don't have symptoms, you can still calculate a cardiovascular disease risk score, which we do for all our patients. The one thing I will say, though, is that the risk scores don't typically take into account autoimmune conditions. So we, in practice, when we see this, we always understand that the risk score will be a little bit higher than what we're getting on the calculator. And in fact, for rheumatoid arthritis, Euler had told us several years ago that it's okay to increase that risk by a factor of 1.5. So if someone's 10-year risk of having a heart attack is 10%, you can make that 15% because they have rheumatoid arthritis. We don't have research that's as appropriate to do that for other autoimmune conditions, but just to know that when you calculate someone's cardiac risk of having a heart attack or a stroke, etc., it's probably underestimated in patients with autoimmune conditions. And then, for psoriasis, they said the worse the condition is, there's research that shows that it's going to increase the cardiac risk. I think it's reasonable for other autoimmune conditions to say that it's going to be really important to try and reduce the burden of the autoimmune disease itself through immunomodulation, through non-medical factors, through lifestyle and other things, to make sure that we are treating those patients appropriately and that we are reducing their cardiac risk by reducing their autoimmune disease risk. And then the last piece of intervention, which we'll talk about in detail now, is how to treat traditional cardiac risk factors. Okay. So now I'm going to change gears a little bit and talk specifically about cardiac risk factor reduction. I will say this is not specific to autoimmune disease. This is for all patients, but it is critical in patients with autoimmune disease, lupus, or other conditions, because it is a really good way to make sure that we're keeping the heart healthy, and that will reduce the cardiac risk in addition to managing the autoimmune condition. So the AHA came out with this, what they call the Essential 8. I do have the link to that here, or you can just Google the AHA Life's Essential 8. And they have really, really nice, patient-centered little leaflets on their website about how to improve these factors. And while a lot of it seems kind of intuitive, I think they have some nice tips and tricks because, everybody's busy. When you're managing a chronic condition, it's really hard to have time to do other things or even feel, well enough to do other things. But it's good to get these little tips of how you can incorporate things into your daily life. So number one is a heart healthy diet, by which we really mean, a diet that is high in fruits and vegetables, high in whole grains, and, low in refined carbohydrates and, moderate amount of good fats. So, for good fats, we say things like avocados, olive oil, etc. But even those need to be moderated because they have, adverse effects on cholesterol if they're too high. Things like nuts, etc., all very healthy, but in moderate quantities. But the things we really want to, increase the consumption of is fruits, vegetables, and lean meats, white meats like chicken and fish. Exercise. So the AHA recommends 30 minutes of moderate intensity exercise 5 days a week. There is room for high intensity exercise, but that has to be managed by symptoms and by overall cardiovascular fitness. But for most people, moderate intensity is a good place to start. That can be something like a brisk walk. It should feel challenging, but it should not provoke symptoms and make people uncomfortable. And what I tell my patients is that, if you start at a certain level, you don't have to start at 30 minutes 5 days a week. You can start with 10 minutes, 3 days a week. But over time, you'll increase it. And over time, your ability to do more will increase and you will feel much better. And that will help both the autoimmune condition as well as the heart. The other things are blood sugar monitoring, making sure the blood sugar is appropriately controlled. If there's pre-diabetes or diabetes, that needs to be treated. And I will say that a lot of the things we talk about are also affected by the, immunomodulators or steroids or other medications. So that does have to be accounted for in treatment. Weight management, which has now changed significantly since GLP-1s, but, is also part of the healthy diet and lifestyle. And making sure that this is monitored, making sure that we can do our best. Sometimes it's not easy when you don't have, the ability to be as active as you'd like, when there are other things going on with chronic conditions. So I think, using the tools we have at our disposal and knowing that it's okay to start small and build up is always helpful. Cholesterol management is something we do in every patient, but is critical in patients with lupus or other autoimmune conditions. So, for the general population, for people who have not had heart attacks or have significant genetic risk, we recommend that their LDL, the bad cholesterol, is under 100 and the good cholesterol is above 50. For patients with rheumatoid arthritis specifically, there's enough data to suggest that their LDL should be under 70. For other autoimmune conditions, we don't have as much data, but we do think lower is better. So if it's someone who's generally, younger, healthy, has room to make diet and lifestyle changes, we will always recommend that first and monitor the cholesterol. But if over time it's not coming down, or if, for instance, a patient has other risk factors, then we may recommend medications for that. Blood pressure, again, it's a really good idea to have a blood pressure monitor at home and to monitor, after you've rested for 10 minutes, make sure that, everything's calm. And then it's a good idea to monitor that blood pressure and make sure that it stays at the goal range. That goal varies depending on whether there are other cardiac issues or not. But for most people, 120s up to low 130s over 80s tends to be a good goal. But that may be more specific based on other cardiac conditions. So it's not a blanket statement, but it's a good idea to, if you have concerns about blood pressure, to make sure you talk to your doctor. Smoking cessation, this is, unlike alcohol, where there is a moderate limit that is okay. Is okay by recommendations. For smoking, I think it's all, all the research shows that it increases cardiovascular risk. There's no question. So, cessation is what our goal is. But sometimes it can be very hard to go from smoking a large amount to completely quitting. So we do have a lot of resources that can help patients get there. But it is important for patients to seek out those resources and partner with their medical team to make sure they have access to what they need. And then the last thing I will say, which I think none of us are, ever gonna find this easy sometimes, but is sleep. It's sometimes it's hard when you're dealing with chronic conditions, etc. It's hard when you're busy at work and life, but I think trying to prioritize sleep as much as you can is always helpful and has been shown in research to improve cardiac outcomes and many other outcomes as well. And so I just put this up. This is for people to review, and it's on the American Heart Association website as well. But just small tips and tricks on how to eat better, how to improve diet, make sure you're having enough hydration and enough water, and different things that we can do. And some places, depending on your medical plan, they will be able to link you up with a dietitian who can, it's just an early consultation to get some advice and have them look at your diet. So if those resources are available, they're quite helpful. Similarly for exercise, so again, the 150 minutes, it doesn't have to be divided 5 days a week. It can be done in any configuration, but it's 150 minutes a week is the goal. And then I will very briefly, for the last slide, just talk about cardiorheumatology, which is, these are the conditions we see in our clinic. There's more than this. But we see several of these conditions in our clinic, just to see the spectrum of autoimmune disease, what we're dealing with, and how we don't have a lot of good research on the specific cardiac issues with patients, but we have enough understanding based on the current research that having chronic inflammation, having autoimmune conditions does increase the cardiac risk. And the cardiovascular societies as well in their prevention guidelines did come out with saying that, if you have inflammation, that puts you it enhances your risk of cardiovascular disease, and that inflammation should be managed, and that cardiovascular risk should be managed, as we've discussed. And a few acknowledgements from the people who've trained me and who've helped me. And with that, thank you so much for being here today, and I'm happy to take any questions.
Thank you so much, Dr. Reejhsinghani. So one question that came up is, what do you recommend in terms of what symptoms should patients look out for and to report to their doctors?
Yeah, absolutely. That's a really important question. So basically, cardiac symptoms, unfortunately or fortunately, will overlap with many other symptoms. things, the most common cardiac symptoms are chest pain, shortness of breath with exertion, palpitations, things like that, swelling, fluid retention, etc. So anything like that, any change in those kind of symptoms is important to report to your doctors. Certainly, lung conditions can also cause shortness of breath. So sometimes it may require a bigger workup that you work up the lungs and the heart. But those are the types of typical symptoms we would want to hear about.
Thank you. And just as a reminder to everybody, if you have any questions, please feel free to write them into the chat or in the Q&A section. Another question would be, what do you see in your practice as one of the more common cardiovascular issues or diseases that patients with lupus have? And
Yeah,
then
so
follow-up is how do you treat it?
absolutely. So I think based on research and statistics, probably the most common and what we see as well in practice is the pericarditis with lupus. So inflammation of the heart layer, the lining. But we also will see patients who have an increased risk of cardiovascular disease, such as cholesterol deposition in the heart arteries, which may or may not lead to a heart attack depending on when it's picked up. So for the pericarditis, that's treated with, actually increasing the immunosuppression, which the rheumatologist will do. And, the one medication that we add is something called colchicine, which has been shown to reduce the risk of recurrent pericarditis. So we'll add that. But typically managing the autoimmune, if there's lupus-associated pericarditis, then usually the rheumatologist will increase the immunosuppression and maybe add steroids for a short time just to calm that inflammation down. We'll add the colchicine and we'll monitor them really closely.
Thank you for that. And then one of the panelists, actually, Yvonne, has a question. You can go ahead, Yvonne.
Oh, okay. I was wondering, are there any blood tests that someone with lupus can take to see if their heart is being affected or if there's a blockage?
That's a great question. So in terms of, blood tests per se, typically it is to make sure we'll check the cholesterol, the entire cholesterol panel. We'll check the hemoglobin A1C, so blood cholesterol and blood sugar. That's the prevention part. In terms of specific, other tests or blood tests as well, it really depends on symptoms. So if someone's asymptomatic, typically we'll stick with the cholesterol, blood sugar, those kind of things. If someone has symptoms, then we certainly do additional cardiac testing. Usually that's in the form of imaging, and we may do some blood work, but for screening, it's going to be more of the prevention.
I have another question. What are some blood pressure medications that some people could take that can that are effective in lowering their blood pressure as well as protecting their heart?
Yeah, so again, I think the key thing there is, especially with lupus patients, is that they make sure that they're going regularly and having, to their rheumatologist, if they have kidney disease, to the nephrologist, and to their primary care, because those are the three groups that are really going to monitor their blood pressure closely. And blood pressure goals may change depending on whether they have kidney disease or other issues. And I think that's where, there are certain medications, for instance, the class is called ACE inhibitors and angiotensin receptor blockers that actually do improve kidney function, but they can also conversely affect kidneys and cause high potassium. So it's very case by case.
Yeah.
So it really needs to be made in conjunction with all the specialists. But I will say that, having untreated high blood pressure is a real issue. And so that needs to be screened for and monitored.
Okay. I have another question. This is involving statins. Because I was recommended a statin when I got really sick with lupus and kidney involvement. I've seen studies on where statins can cause kidney damage. Is that true, or have you seen any of that research?
Yeah, so most of the studies with statins, have the biggest side effect of statins that has been proved in research, and this is, evidence, high quality research, is typically that about 5% or so will have muscle myalgias, muscle pain, but that's less than 5%. With the kidneys, there is some data that it can increase blood sugars. There are some statins that are cleared by the kidney, for instance, rosuvastatin. So there is an upper limit on the dose we would use in someone with
Right.
significant kidney function. So I think it's also important, the selection of statin, and to make sure that it's the safe, a safe statin depending on someone's kidney function.
The reason why I'm asking you this, because I've been doing a lot of research. I did have a heart attack. So I had a transplant. And so these medications for my heart are causing my kidney transplant, reducing it. And so I've been doing a lot of research on, antiplatelet, like I'm on Brilinta, and I saw that in research that that it does cause issues with the kidneys also. So it's very difficult for me to try and tell my team of doctors what, I'm looking at this research through NIH, and it's telling me that some of the medications that they're giving me is causing kidney failure with my transplant. And so it's very frustrating to deal with this. What do you think about red yeast rice? Have you heard of it?
There is some data on that, but again, that's in patients who can't tolerate any of the traditional cholesterol lowering medicine.
Yeah.
So I do think, specifically, thank you for sharing that, and sorry for all the things you're going through. But
Yeah, it's okay.
But I do think that in these situations, and we certainly see a lot of patients where there's, a lot of competing issues going on. So it's a good idea for the teams to talk to each other and make sure that they're all on the same page,
Yeah.
Nephrology, cardiology, for instance. We do that a lot. We, in fact, have a lot of, the nephrology, cardiology, and rheumatology will talk about, especially our more complex patients. So to make sure, because everybody's perspective is a little bit different, everybody's expertise is a little bit different.
Yeah.
So it's good for us to all discuss, and we do this routinely because of the complexity of these situations. But again, we definitely have strong data that in people who've had heart attacks, cholesterol lowering, with statins, or now we have PCSK9 inhibitors, those medications does prevent future cardiac issues.
Okay. Thank you.
Sure.
I think that's all that I have. Are there any new anti-platelet medications that are down on the pike? Are you aware of? Because I know of Plavix and Brilinta. Do you know of any other effective?
Yeah, so the three that we use in practice now, mostly that are oral, are Plavix, aspirin, of course, because that is the intended, but Plavix, which is clopidogrel, Brilinta, which is ticagrelor, and Prasugrel, which is another one. So those three are the ones that are used in practice, and there are slight differences in efficacy versus side effects. So again, individualized decision, but those are the three main ones we use in practice.
What was the third one?
Prasugrel.
Prasuk. Is there a brand name for that one?
The brand name is, I am not sure actually. But Prasugrel is the generic name, which is usually the ones that we talk about.
Okay.
Thank you, Yvonne. Do you have any other questions?
I think that's it.
Okay, thank you for your questions.
Thanks.
Dr. R, thank you so much for your presentation. We really appreciate your time and your expertise. Thank you.
Thank you so much for inviting me.
Thank you.
It's been a pleasure. Thank you so much.
Thanks so much.